Cytology is the art and science of looking at cells to understand what's happening in a tissue. It's one of the most valuable and most accessible diagnostic tools in practice. A fine needle aspirate, a smear, or an impression can give you an answer in minutes that might otherwise take days and a biopsy to discover. Today, we're going to take a systems approach. Instead of memorizing cell names, we'll think about what categories of cells show up, what they tell us, and how to communicate what we see to a clinical pathologist. The biggest question clinicians ask when they find a mass is, what is this? Cytology gets you an answer quickly and cheaply. A fine needle aspirate, a small needle, a syringe, 2 or 3 pokes into a mass, gives you cells to look at within minutes. It's so minimally invasive that most dogs and cats tolerate it awake. The most important thing cytology can tell you is whether a mass is inflammatory, meaning the body is reacting to something, or neoplastic, meaning abnormal cells are growing. That distinction alone changes your entire workup plan. The limitation is that cytology doesn't preserve tissue architecture, so it can't tell you as much about tissue invasion or precise tumor grade. That's what histopathology is for. But cytology tells you whether you even need to go that far. Every sample you look at will fall into one of 3 buckets. First, inflammation. You'll see lots of immune cells responding to something: bacteria, a foreign body, a fungus, or a sterile inflammatory process. Second, you might see hyperplasia or normal tissue. The cells look fine, they're just present in large numbers or were sampled as a normal structure. Third, neoplasia, abnormal cells that don't belong in the tissue, showing features of uncontrolled growth. Learning to place a sample in the right bucket is your first goal. Everything else, specific diagnosis, prognosis, treatment, flows from that first classification. To determine a sample is inflammatory, your next question is, what type of inflammation and is there an infection? Suppurative inflammation, lots of neutrophils, is your first clue. Now look carefully at those neutrophils. Are they non-degenerate, meaning their nuclei look dark and segmented and healthy, or are they degenerate, swollen, pale, losing their nuclear structure? Degenerate neutrophils means there's a toxin in the environment, usually bacterial toxins, and you should search carefully for organisms. Bacteria inside cells is very supportive of a true infection. Granulomatous inflammation, macrophages dominated, points toward more chronic or unusual causes like fungi or mycobacteria, and eosinophilic inflammation makes you think of parasites, hypersensitivity reactions, or certain tumors like mast cell tumors that have eosinophils in the neighborhood. Recognizing malignancy in cytology comes down to the nucleus. Normal cells have small, uniform nuclei with a modest amount of cytoplasm around them, and nucleoli that are small or invisible. Malignant cells lose those rules. The nucleus gets huge relative to the cytoplasm, high N to C ratio. The nuclei vary dramatically in size from cell to cell. You see multiple large irregularly shaped nucleoli. The nuclear factory is running out of control. Abnormal mitotic figures, where the chromosomes aren't dividing evenly, are a very strong sign of malignancy. You don't need all of these features, but the more criteria present, the more confident you can be that you're looking at a malignant neoplasm. These are the features your clinical pathologist will report on, and understanding them helps you communicate about the case. Neoplastic cells come in 3 basic architectural flavors: Round cell tumors, lymphoma being the classic example, shed individual cells that roll around freely on the slide. They give you beautiful cellular samples and are very cytology friendly. Epithelial tumors, carcinomas, come from cells that stick together, so they exfoliate in sheets or clusters. And mesenchymal tumors, sarcomas, come from connective tissue cells that are firmly embedded in a matrix, so they don't exfoliate well at all. A sarcoma aspirate often looks almost acellular, just a few spindle-shaped cells, which can be frustrating, but is actually informative. A mass that gives you almost nothing is suspicious for a mesenchymal tumor and is a prompt to go to histopathology. Node aspirates are one of the most rewarding cytology samples because normal lymph nodes have a very consistent appearance, mostly small, mature lymphocytes, and any deviation from that is meaningful. A reactive node has a mixed population, including plasma cells and large activated lymphocytes called immunoblasts, which tells you the node is responding to antigenic stimulation, usually infection nearby. Lymphoma gives you the opposite of normal. The node is flooded with large, immature, often monomorphic lymphoblasts that have replaced the normal architecture. And metastatic disease is diagnosed when you find cells that simply don't belong in a lymph node, like a cluster of epithelial cells from a carcinoma that is spread to regional nodes. Lymph node aspirates should be part of your standard oncology staging. The most underappreciated part of cytology is the submission process. You can have the most beautiful cells on a slide, but if you fix them in formalin, which is the fixative for histopathology, not cytology, the stain won't work and you'll get nothing useful back. Cytology slides are air dried. Make several slides from each site. Sometimes the first couple will be too thick or too spread out, and slide 3 is the one with perfect cell distribution. And fill out your submission form with real clinical information. The pathologist reading your slide doesn't know this animal. Telling them splenic mass 3 centimeters, 9-year-old golden retriever, spleen palpable, makes a huge difference in the quality of interpretation you get back. Leave you with a quick gallery of the most common cytologic findings you'll actually encounter in practice. Mast cell tumors are incredibly common in dogs, and the diagnosis is often made on cytology alone. You'll see round cells packed with purple metachromatic granules alongside eosinophils. Lipomas, those soft, squishy, fatty masses, give you a slide full of clear, fat vacuoles with no nuclei, which is almost pathognomonic. Abscesses are degenerative neutrophils with bacteria. The picture practically diagnoses itself. Lymphoma usually gives you a strikingly monomorphic sheet of large immature cells that look nothing like a normal lymph node. And transitional cell carcinoma in the bladder is an important one. Atypical epithelial cells in the urine or a bladder fine needle aspirate should prompt you to send to a pathologist and not dismiss it as cystitis. These are the diagnoses you'll make with cytology regularly, and recognizing them quickly changes patient outcomes. Wrap up. Every cytology sample answers one question first: inflammation, normal, or neoplasia. From there, you characterize the type of inflammation or the type of tumor. The nucleus tells you about malignancy. Lymph nodes are a staging goldmine. And please remember, air dry your slides, never formalin. Cytology is one of the fastest, most rewarding diagnostic tests in practice. A well-made slide with good clinical context can give you an answer in 24 hours that changes a patient's outcome. In 1, almost every cell is large, immature, and looks the same. Normal lymphocytes are barely present. Prominent nucleoli, occasional mitoses. What are you looking at, and why does the monomorphic population matter? This is textbook large cell lymphoma. The key finding isn't just that the cells are large, it's that they've replaced the normal population. A reactive lymph node has a mixed heterogeneous population of cells in different stages of activation. Lymphoma creates a monomorphic population. One abnormal cell type has clonally expanded and taken over. In a 9-year-old golden retriever, this presentation fits the classic demographic. Lymphoma is one of the most common cancers in this breed. The cyto the cytologic diagnosis is highly supportive, but immunophenotyping, figuring out whether this is B cell or T cell lymphoma, is important for prognosis and treatment protocol selection. This dog needs staging and an oncology conversation. Question 2. Purple granules inside and outside the cells, round cell tumor, eosinophils in the background. What's the diagnosis, and is there anything to be cautious about when you're performing this particular aspirate? Mast cell tumor, one of the most cytologically satisfying diagnoses because the purple granules are so distinctive. The eosinophil association is a classic secondary finding, but the important clinical teaching point here is degranulation. Mast cells are loaded with histamine and other vasoactive substances, and if you manipulate the tumor aggressively or during surgical resection, you can trigger systemic release of those mediators. The dog can go into anaphylactoid shock. For this reason, before any mast cell tumor surgery, patients should be pre-medicated with antihistamines, both H1 blockers like diphenylhydramine and H2 blockers like famotidine. Cytology is great here, but you'll need histopathology to grade the tumor and determine prognosis and margin assessment. Question 3. Almost no cells, clear vacuoles, no nuclei visible. This slide looks almost empty. What are you looking at, and is this a reassuring or a concerning finding? Cells, adipocytes, are one of nature's least photogenic cell types on a cytology slide. The lipid droplet takes up the whole cell and pushes the nucleus to the very edge where it's essentially invisible. So a lipoma looks like a slide full of clear bubbles with almost nothing else on it. And that's exactly right. In the context of a soft, squishy, freely movable subcutaneous mass in a middle-aged to older Labrador, the classic patient, this is a very reassuring finding. Lipomas are benign, but always note the location and behavior of the mass. If it's firm, deep, infiltrating between muscle plans, or not freely movable, you need histopathology because infiltrative lipomas and liposarcomas exist, and you don't want to miss them based on cytology alone.